They don't have the big highs and the big lows from the testosterone. It's also a lot nicer to inject something sub-Q than IM. Well, these are not all the things we can do. These are the things that I gravitate towards on the hormone side of things. Remember, there are a lot of other things that you can do in the therapeutic order to improve testosterone. This is not the course on how to follow the therapeutic approach for hormone replacement therapy. This is talking about when you want to use bioidentical hormones and other things in endocrinology, how are we going to use them? So, men, I prefer HCG if LH is less than 10. Right? Because remember, when LH starts going high, it means the actual Leydig cells are not producing testosterone. HCG is an LH analog, so giving more LH is not going to be the answer. It's not treating the cause. So if LH is less than 10, I tend to like to start with HCG. I actually used to start with clomiphene. Probably about 6 to 8 months ago, I started rethinking that. The reason why is because clomiphene is an estrogen blocker in the brain. That's how it tricks your body into making more LH. So our brain registers, and this is men and women, but we're talking about men right now. The brain registers estrogen levels more so than testosterone levels for the production of testosterone. So if we go in and block the estrogen receptor and trick the brain into thinking that we have low estrogen levels, the body thinks we have low testosterone levels, it increases LH and more testosterone is made. That's how clomiphene works in men. My concern goes back to estrogen. To my knowledge, the receptors that clomiphene is hitting as an estrogen blocker in the brain is not just in that little portion in the brain that controls LH. It's widespread. So, is there a potential risk of making the brain, other cells in the brain, not get enough estrogen? I think so. There's not a lot of great research on it, but I'm concerned about that. So in our first do no harm, if I have two roughly equal options for efficacy, these work equally as well most of the time, I'm going to choose the one that I think is less potentially harmful to the patient. So I've been using HCG more so than clomiphene recently. I'll only go to clomiphene if HCG fails. And if HCG fails, I might even just skip clomiphene and go to testosterone, because that's how much I'm concerned about blocking estrogen in the brain. Okay? In terms of the different approaches you can do for actual replacement, you can do pellets, you can do troches, you can do creams, you can do injections. Those are basically the main ones. As you can see, I have 2 of those 4 listed. I have injections and I have a cream. I don't like pellets, I don't like troches. I don't like pellets because the theoretical aspect of it is beautiful. We give you 1 insertion of a pellet and that stays in there for 3 months and your levels are just going to be phenomenal. Most of the time, the first few doses suck for patients. It's either too little or too much. Too little, well, it's a waste of money. Too much, maybe there's a potential risk of clotting due to increased hematocrit. So go give blood to offset this. I also think about if this is a therapy that my patient might be on for the rest of their life, and they're 50, and they're going to live to 90, every 3 months, so 4 times a year, they're having an incision into an area where we get a cross between the upper body and the lower body, the left side and the right side, in their glutes. There's also a lot of nerves, cluneal nerves, that are in that area that are a chronic cause of low back pain. So, 4 times a year, for maybe 40 years, worst case scenario, 160 incisions into the low back over that time. It's a lot of scar tissue. So we need to do all of our things that we're talking about scar tissue to fix that, right? So I don't like it for that reason. I'm not saying it doesn't work, because it can work really, really well, but I just don't like that aspect of it. Troches, again, theoretically, great. It's absorbed sublingually. Yeah, a really small portion of it is absorbed sublingually. Try putting even a Mentos in your mouth and not swallowing any saliva. Good luck. You're going to swallow that, that's going to go through the liver, and then we get back to the whole issues of increasing hepatic demand for the hormones that are hitting the liver in the first pass effect. So I like avoiding the first pass effect whenever possible, unless there's research to show that the levels of hormones that we're doing, such as oral progesterone, oral pregnenolone, oral DHEA, are not causing extra harm to the liver. And those are the three that I use orally. So, injection, cream. This is usually based on preference for the patient, okay? If you're using creams, there are different types of creams you can use. There's your basic transdermal cream, which is the VersaBase. Okay, so if you're talking with the pharmacist and you're asking about the different types of creams they have, talk to them about this, okay? VersaBase is your transdermal cream. Then there's usually a lipodermal cream, which is a bit more lipophilic, and so it helps to drive the hormone into the skin better. There's a new one out on the market that I've recently been using that I like, which is called, still a transdermal, but it's called a Trevis. Okay? You'd ask your compounding pharmacy when you're working with them if they use the Trevis base. If not, the one I use here in Gilbert called Strive uses a Trevis base, and they're actually the ones who introduced me to it. Compared to the VersaBase, you get about a 2-fold increase in blood levels with testosterone, which means we can use less testosterone in the cream to get our desired effect, which I think is beneficial because there's less chance for that testosterone in the cream causing a local hirsutism or increased for women especially, but increased hair growth, increased conversion to DHT in the skin, things like that. And because there's less testosterone, less risk of contamination, and it also dries a lot faster than the VersaBase. So you'll notice that the dosages tend to be a little bit lower than what you're looking at on other things because the driver and the gel matters. So typically for the transdermal, we're looking at starting about 25 milligrams a day. Normally, you're starting at about 50 milligrams a day in the VersaBase, but with the Trevis, we're starting at about 25. And you can go up to basically 100 milligrams in some patients, if need be. But you start lower and work up. With the injection, it's the standard 200 milligrams per ml. I've actually started switching some of my patients and seeing really better results with daily sub-Q injections of testosterone. So a lot lower doses. But what we get is, instead of a big bolus dose of testosterone, 200 milligrams that week, which that hits your kidneys pretty hard and can actually impact kidney function, and then this, and then this, and then this. And some patients will notice that. They feel phenomenal for 2 to 3 days after their injection, and then they feel like crap the days coming up to their injection if it's done bi-weekly at 200 milligrams. Going to weekly at 100 milligrams, they do better. It's less intense. But you start doing sub-Q injections daily, and you'll start to notice this. They don't have the big highs and the big lows from the testosterone. It's also a lot nicer to inject something sub-Q than I am. So you use a 1/3 insulin syringe, and you're doing anywhere between 5 to 12 IUs a day. Starting at 5 IUs a day. Okay?
And then are you just basing on symptom improvement, or do you recheck labs at a certain amount of time, or a little bit of both?
A little bit of both.
Okay.
Initially, it all goes off of the way I think of it is this. If we start on 5 and after 6 to 8 weeks, patient's like, yeah, I'm 30, 40% better, but I still have this symptom, this symptom, this symptom. I don't need to check labs. I just need to increase their dose. We increase their dose. Typically what I do is we increase the dose until they feel better, until they feel good, and then we recheck labs to see where they're at.
So if you had a patient with low T who is like in their 20s, are you still going to recommend like testosterone replacement for that patient?
Typically not.
Right. So how would you, if their LH was normal, how would you go about increasing testosterone with that patient?
So if we wanted to go medication route HCG, not exogenous testosterone.
Even if LH was,
you said normal.
high enough. Yeah.
Right. So if LH is normal, then HCG would work.
Oh, I see. Okay.
We don't do it if LH is higher than 10.
Higher than 10.
Yeah.
Okay.
But a lot of the times with the younger, like a 20-year-old with clinically low T,
Yeah.
there's something usually either pathological going on that's dropping it, or it's like major lifestyle stuff.
Okay.
They eat like crap, they don't sleep, they don't exercise, and so it's doing all of that stuff
That's really
that is going to help them get back.
Mm-hmm.
Now, I've worked with also a few patients who they're 26, 27 years old with clinically low T, and it's from doing steroids in high school. So then that's a different story.
Yeah.
That's like, okay, you caused some changes that we are working uphill against. So it's not just sleep better, eat better, and exercise, because we've screwed up the HPG axis from anabolic steroid use. Okay?
Mm-hmm.
Females, you can also do injections. Okay? This is not the other nice thing about this, a bottle of testosterone cypionate for a patient is like $100, and that'll last them 3 to 6 months. The cream tends to be about $30 to $50 a month through a compounding pharmacy. So cost is a thing as well. And I tell that to patients in their decision on which one they want to do. Unfortunately, testosterone cypionate comes commercially in 200 milligrams per ml. Okay? Even if you get it from a compounding pharmacy to not do the peanut oil and to do the grapeseed oil, you're still only looking about $100 for a 3 to 6 month supply. When you start playing around and doing 50 milligrams per ml, cost goes up because it's not standard. So typically, also men seem to be usually pretty okay with stabbing themselves with a needle. Women, for some reason, not. Okay? So I tend to usually use creams in women more so than injections. Also, typically with women, if we're doing testosterone, there's a good chance we're also doing estrogen, and so it's easier to put both of those in a cream together. You can't use the Atrevis base with estrogen. The Atrevis is just for testosterone. So if you're going to be doing a combination of testosterone and estrogen, we still don't want to do the Versa base, but we do that middle of the road one, which is the lipodermal. So it's still liposomal, more lipophilic, helps drive it, but it's not as good as the Atrevis, but it's better than the Versa. Starting at about, if we're doing the Atrevis, at about 0.25 milligrams a day in women. If we were doing the Versa base, we'd basically be starting at about 0.5 milligrams per day, right? Because there's that 2-factor difference. You can go up to about 1.5 milligrams a day in testosterone with the Atrevis, and 2 to 3 milligrams a day on the in the regular Versa base.